10 years ago, few people really would have predicted the extent to which the rare disease space has evolved. One of the most frequent questions we get from our client is about what to expect in the next 10 years and how they can prepare. And this is what we're answering with Project LEOPARD, how things are evolving and what are the key trends that are likely to shape patient access in rare disease over the next 10 years. And today, we look at the pricing and market access landscape. If we look back to the space 10 years ago, there were relatively few manufacturers investing in orphan diseases, and the regulatory incentives and pricing and market access provisions were still in their infancy. In the last decade, however, many more manufacturers have entered the rare disease space, and the number of marketed and pipeline orphan drugs has grown substantially. Ultimately, this has led to a greater number of patients treated and the emergence of competitive forces in rare diseases. In that time, policymakers have had to adapt regulatory pathways, and payers in some markets have started to adapt HTA and pricing processes to accommodate rare disease intricacies. To explore the trends that are likely to shape the rare disease space over the next 10 years, we gathered insights from rare disease experts across the US, Europe, and subject matters, including policy, pricing, market access, and commercial strategy. To frame the assessment, we centered on 3 categories of rare diseases. Category 1, so-called competitive rare diseases, would be diseases with multiple treatment options that may create payer pressures not seen in other rare diseases. So, for example, we could be looking at ATTR or PAH. The second category corresponds to most rare diseases, where unmet needs are high, treatments option limited, and sometimes even non-existent. And finally, category 3 is probably the less intuitive of the 3. It's looking at rare subcategories of non-rare diseases.
Looking at category 1, the competitive rare diseases, manufacturers may face certain challenges, starting with a higher bar of evidence. In this space, we expect that the traditionally lower evidence expectations from payers for rare diseases will not be accepted, and submissions are likely to be scrutinized to a greater extent than for rare diseases with no standard of care or higher unmet needs. Therefore, if unmet needs are somewhat addressed by early launches within the competitive space, manufacturers may need to seek out a niche with a higher need, as we now see in diseases like PAH, where products are specific to certain lines of therapy or subpopulations to preserve price potential and value proposition. Another key characteristic of this space will be price pressure, unlike that seen in other rare diseases. With increasing competition and potentially increasing diagnosis rates, manufacturers should expect to see substantial downward price pressure for latecomers, especially at the net price level. And payers are also more likely to impose restrictions or impose some type of treatment sequence that could be based on a combination of both price and efficacy. And then at the local level, there's likely to be negotiations to ensure inclusion on formularies. If multiple players are in the market, we expect an increase with tenders or some form of competitive procurement. And companies may be unable to avoid the type of payer management traditionally applied to non-rare diseases. So if the disease area has witnessed some loss of exclusivity, this is likely to exacerbate price competition. We can potentially expect biosimilar and generic manufacturers to capitalize on the high prices seen in some rare diseases, although we do anticipate less aggressive pricing strategies given the relatively small target population. So, what should manufacturers who currently play in those more competitive rare diseases or who are planning to enter be looking out for? This can be summarized in 3 recommendations. Firstly, make sure that the evidence packages are comprehensive and future-proof, considering the future dynamics of the disease area, and that the robustness of evidence at least matches that of previous launches within the space. Secondly, look again at your pricing strategies. Here, price pressures will be different to those of traditional rare diseases and more akin to broader therapy areas. So be clever about how you use contracting options with payers to differentiate. And in some cases, you may need to build internal capabilities for tendering excellence, local formulary negotiations, or LOE strategies. And finally, be prepared for tough negotiations. Your value proposition needs to be clear, differentiated where possible, and supported by evidence. Your negotiation strategy needs to be progressive, rehearsed, and with clear goals. This is it for our first installment. Stay tuned for more of Project LEOPARD, including looking at the evolution and outlook for rare disease policy and commercialization. Go ahead and click the link in the post for more information and related rare disease insights and developments from CRA.